ARDS that I'm sure all of us knows about it. We all know that ARDS is a clinical syndrome. It's not a disease. It's characterized by diffuse alveolar damage, inflammation, and edema, causing acute respiratory failure with impaired gas exchange and oxygenation. Its incidence among critically ill patients in ICUs is about 10%, and the mortality rate is up to 40%. The definition of ARDS was first established in 1994 when American European Consensus Conference established the first criteria, which were updated in the Berlin Consensus in 2012. Four main items represent the main diagnostic criteria about the timing, within 1 week of a known clinical insult or a new or worsening respiratory symptoms. The second item is the chest imaging, bilateral opacities not fully explained by pleural effusion or lobar or lung collapse. The origin of edema is a respiratory failure not explained by cardiac failure or fluid overload. This can be assessed by echocardiography to exclude hydrostatic edema. Then it's further classified into 3 stages: mild, PF ratio from 200 millimeter mercury to 300 millimeter mercury, moderate from below 200 to 100, and severe PF ratio below 100. These criteria was further updated in 2023. The new updates were intubation is not always required, and the new high-flow nasal cannula more than 30 liters per minute is introduced into the criteria. Secondly, the hypoxemia, PF ratio below 300, or the SpO2 over the FiO2 below 315. The bilateral opacities in the chest imaging is identified by chest radiograph, CT, or an ultrasound. In resource-limited settings, the following are not required: PEEP, oxygen flow, or specific respiratory support device. This was a quick review about the ARDS that I'm sure most of us knows already. Now we are going to discuss the new management and its ventilatory golden rules. There are 10 rules about the management of ARDS. The first rule is the low tidal volume ventilation from 4 to 6 milliliter per predicted body weight. The second rule is the plateau pressure below 27 centimeter water. Rule 3, the driving pressure below 15 centimeter water. Rule 4, respiratory rate below 30 breaths per minute. Rule number 5 is PEEP below 15 centimeter water. Rule 6, mechanical power below 17 joule per minute. Rule 7, prone positioning. Rule 8, neuromuscular blocking agents. Rule number 9 is recruitment maneuvers. And rule number 10, considering extracorporeal CO2 remover and ECMO. We'll discuss each rule in details. The first one is tidal volume. The cornerstone of lung protective ventilation was the ARMA trial. It demonstrated that a low tidal volume, apparently 6 milli per kg predicted body weight, compared with a higher tidal volume of 10 to 12 milliliter per predicted body weight, improved survival. A study was with 482 patients with ARDS found that every 1 milliliter per kg increase in tidal volume above 6.5 milliliter per kg was associated with a 23% increase in mortality in ICU. Moreover, patients exposed to lower tidal volume from the beginning, even in the emergency department, had an overall lower risk of ICU mortality compared with those who received higher tidal volume, followed by a low tidal volume. However, there is still a debate regarding the timing of initiation of protective ventilation. The second one is the PEEP. The application of positive end expiratory pressure results in benefits such as alveolar recruitment, reduction in intrapulmonary shunt, and increased arterial oxygenation, despite its drawbacks such as increased risk of volutrauma and reducing cardiac output. 4 large randomized clinical trials enrolling 300 to 1,064 patients have compared higher PEEP with lower PEEP, and all failed to improve survival with higher PEEP. Now we'll discuss the driving pressure and plateau pressure. What's the driving pressure? It's the plateau pressure minus the PEEP. There is still a debate about which is more important in prediction of ICU mortality. The lung safe trial showed that driving pressure below 14 centimeter water was associated with decreased risk of hospital mortality in patients with moderate to severe ARDS. And these results were even confirmed by a meta-analysis of 9 prospective trials involving more than 3,500 patients, which showed that driving pressure was the best correlated with survival in patients with ARDS, while a recent study from Velar reported that plateau pressure was a more important determinant of mortality and outcome than the driving pressure. Therefore, the literature suggests that driving pressure should be kept below 13 to 15 centimeter water and used in association with a low tidal volume and a plateau pressure below 30 centimeter water, as well as the lowest PEEP that can keep oxygenation at an acceptable value. The respiratory rate. Before we discuss the respiratory rate, we have to be familiar with the term lung strain. What's lung strain? It's defined as the ratio of tidal volume over the end expiratory lung volume. For the lung strain has been used to determine safe thresholds for tidal volume to prevent ventilator-induced lung injury. And what's the strain rate? That's the change in lung strain with respect to time. So this reflects that a high respiratory rate alveoli will have less time to inflate, and longer times are related to lower strain rates, and shorter times are related to higher strain rates. Thus, we need to highlight that slow changes in ventilatory parameters should be preferred over abrupt changes to limit further damage to the lungs. Now, the mechanical power. It's the amount of energy transferred by the mechanical ventilator to the respiratory system per unit of time, and is determined by combined effects of applied tidal volume, respiratory plateau pressure, respiratory rate, inspiratory flow, and PEEP. In a recent experimental study, mechanical power above 25 joules per minute caused more significant and potentially lethal lung damage than lower values. However, the benefit of mechanical power is still unclear, as its clinical use is limited by the complexity of measuring and interpreting it. Other modes of ventilation. We will discuss 2 modes, the airway pressure release ventilation and the high frequency oscillatory ventilation. Let's begin with the APRV, high airway pressure release ventilation. It's an elevated CPAP level with timed pressure release. These modes allows for spontaneous breathing. These breaths can be unsupported or pressure supported or supported by automatic tube compensation. The key is a dynamic expiratory valve in the circuit, which allows spontaneous breathing at high lung volumes. Several studies concluded that APRV increases compliance, oxygenation, and hemodynamics in comparison with a lung protective ventilator strategy. Also resulted in reduced mortality, duration of mechanical ventilation, and ICU length of stay. However, when setting APRV, we should always keep in mind that the data available are not sufficient and that APRV represents a pressure control modality of ventilation with potential for volumetrauma if not properly set. The second one is the high-frequency oscillatory ventilation. This mode uses a constant descending pressure with pressure variation oscillating around the map at very high rates. High-frequency oscillatory ventilation is actually not recommended by guidelines for its potential for high intrathoracic pressure, altered hemodynamic response on ventricular preload, pneumothorax, airway obstruction, acidosis, and cellular injury. Guidelines suggest using this modality only in cases of rescue therapy or as a research target in those patients who cannot tolerate high tidal volume and standing pressures. Prone positioning. Prone positioning in patients with ARDS improves oxygenation, increases recruitment potential, and reduces areas of alveolar overextension, thus ensuring more homogeneous aeration of the lungs and potentially reducing ventilator-induced lung injury. The initial evidence from the PROSOVA trial was the first study to show a benefit of the prone positioning or mortality for patients with moderate to severe ARDS with PF ratio below 150 millimeter Hg, with 60% FiO2 and PEEP of at least 5 centimeter water for at least 16 hours until clinical improvement. Results was improvement in mortality rate at day 28 and day 90 with 33% and 41% respectively. International guidelines now recommend that the prone position should be instituted early and ideally within 36 hours of meeting this criteria, and should be used alongside lung protective ventilatory strategies. What's ECMO? Extracorporeal membrane oxygenation. Mainly, the venous ECMO has been considered as a rescue therapy for patients with severe ARDS due to the complications related to it and the controversial evidence. The multi-center Caesar trial compared ECMO with conventional management of ARDS and showed that 76% received ECMO had an improvement in the primary outcome of the quality of life at 6 months. EOLA trial showed a signal toward improvement in mortality, but it didn't achieve statistical significance. ECMO has also been shown to be effective in COVID-19 and reduce mortality compared with conventional therapy. Similar to it was the extracorporeal carbon dioxide removal. It can manage both hypoxemic and hypercapnic respiratory failure. It uses a blood flow of around 0.5 to 1.5 liters per minute, allowing removal of low flow CO2 and pH control while avoiding the invasiveness of ECMO. Recent systematic review of both randomized controlled trials and observational studies concluded that evidence is lacking to confirm beneficial effects of extracorporeal CO2 removal on outcome in ARDS, although positive insights about the lung protective ventilation and ventilator-induced lung injury were found. Fluid management. The leading trial in fluid management was the FACT trial, was defining the trial testing the effect of a conservative fluid strategy in ARDS. The trial adopted active diuresis, fluid boluses, vasopressors, plus minus inotropes, based on the varying ranges of central venous pressure and pulmonary artery occlusion pressure. The results suggest that liberal fluid management may be more harmful in patients with ARDS by increasing pulmonary edema and prolonging mechanical ventilation days and ICU and hospital stay. That was the golden rules for ventilatory management. Now we will discuss the pharmacological therapies for ARDS. We will discuss about 14 new therapies for ARDS. Some has some evidence in guidelines and most of them are not. And we will know later why most of them is still not useful. The first is neuromuscular blocking agents. They paralyze skeletal muscles by blocking the transmission of nerve impulses at the myoneural junction. Their current status in the guidelines, it's considered in cases of early and severe ARDS with deep sedation, invasive mechanical ventilation, and the need for prompt positioning within 48 hours. There is no evidence to support neuromuscular blocking agents' routine and early use. Second is corticosteroids. Their anti-inflammatory expression is regulated in the nucleus by the activated glucocorticoid receptor glucocorticoid complex, thus reducing inflammation. And their current status is, according to the current research, there could be a significant patient benefit and the risk of adverse events is thought to be low. However, not approved at the medical treatment guidelines with no clear benefits and outcome. That were the two pharmacological therapies that have a limited role in the guidelines. Aspirin, interferons, vitamins, statins, all other pharmacological therapies are not approved and there are no clear benefits and outcome. We'll discuss them. Aspirin reduces pulmonary neutrophil infiltration as well as alveolar inflammation and injury, while interferons facilitate clearance of bacteria, neutrophil apoptosis, and efferocytosis and promote lung repair. Statins acts via inhibition of HMG-CoA reductase and also have many other pleiotropic effects such as anti-inflammatory and anti-proliferative effects on lung inflammation. N-acetylcysteine acts as an antioxidant. Beta agonists reduce bronchospasm, airway resistance, and inflammation, as well as improve alveolar fluid clearance and stimulate alveolar epithelial and endothelial repair, thus benefiting pulmonary mechanics. Civilistate is an inhibitor of human neutrophil elastase. In ARDS, it improves oxygenation and reduces inflammation. Vasodilators such as nitric oxides and prostaglandins have vasodilatory properties, while surfactants act by reducing alveolar surface tension, thus preventing alveolar collapse and limiting pulmonary edema. Surfactants also have anti-inflammatory and antimicrobial properties. Solanotide is a synthetic peptide that reduces extravascular lung water and activates epithelial sodium channels, thus improving lung functions. Dilmapyomide is the p38 mitogen activated protein kinase. It reduces the levels of the pro-inflammatory cytokines and chemokines, as well as cell infiltration to inflammatory sites. Keratinocyte growth factors and granulocyte monocyte colony stimulating factors inhibit apoptosis and has mitogenic effects. They also stimulate maturation of alveolar epithelial cells. Nebulized heparin improves oxygenation and reduces lung edema, and mesenchymal stem cells modulate the immune response and reduces lung injury. And now we're going to ask the most important question. Why do pharmacotherapies fail in ARDS? As we noticed before, we discussed about 14 pharmacological therapies. Most 12 of them are not, they don't have any approved outcome or clear benefits. That's why the supportive treatments have shown some positive results in the treatment of ARDS over the years. However, pharmacotherapists have not presented similar benefits, which may attribute it to the heterogeneity of the disease. That's what's the most important thing is ARDS is not always the same in all patients. It has some heterogeneity. So there are two approaches for introducing pharmacotherapies in ARDS. The standard approach, we apply all the pharmacotherapies to all patients, and the results we already got were failed, all drug tested. While in the personalized medicine, we classified ARDS patients into two groups, the hyperinflammatory subphenotype and the hypoinflammatory subphenotype. The main differences between hyperinflammatory and hypoinflammatory is the hypoinflammatory has less abnormal laboratory functions and less organ failure, while the hyperinflammatory has very severe inflammatory response and abnormal labs and much more organ failure. We already found that the hyperinflammatory subphenotype, the liberal fluid strategy was more appropriate with that phenotype. Still, the simvastatin was still appropriate other than other types of statins. While the hypoinflammatory subphenotype, the conservative fluid management was more appropriate, and higher PEEP had very good results in the hypoinflammatory. So when we classify the ARDS patients, some of them benefit from the pharmacotherapies and some benefits from the other therapies. The future directions for the ARDS is understanding more about the etiology, physiology, and subphenotypes. Further investigations are required to identify treatable traits, how to select the patient, and how to allocate patients to receive one therapy instead of another. Thank you.
Thank you. So what is the treatment of ARDS?
Still no one knows.
شكرا المناقشة. رد يا أستاذ عاصم، يا معتز عاصم.
Like we said, ARDS is very complex.
سؤال تاني يا سماح.
سؤال تاني يا
واضح
فندم؟
ان رول انت الصوت كمل يا معتز الرد على السؤال.
والسؤال كان التريتمنت اوف ARDS. ARDS is very complicated. We still don't know much details about it. The take-home message of this paper is that we still need more investigations, more classifying patients, so we can know who will benefit from what. That's the take-home message.
في واحد بيقول لك I love to learn more about it. دي عايزة احنا قلنا الدكتور ياسر نصار تقريبا محاضرة sophisticated لمدة ساعة من أسبوعين كان فيها التفاصيل مهمة. Yes, so we are going to put the lecture on a site of our YouTube called Hassan Khalid Nagy Journal Club. So wait, this lecture and another lecture 2 weeks ago, sophisticated about ARDS, so you will see it. وبس what انت بتتكلم عن الهايبر انفلاميشن والرول بتاعتها في ار دي اس، وكاتب السيمفاستاتين على انهم انتي انفلاماتوري افكت. اللي اتقال اللي كان من ايام، لقوا ان الستاتين مش كافيه جدا تو بريفنت الأثيروسكلروزس، وان الانفلاميشن مهم جدا ولازم تعمل للعيانين هاي سنسيتيف سي ار بي عشان دول تديهم بقى انتي انفلاماتوري. وجابوا سيرة طبعا ان الكولشيسين ناو is approved في التريتمنت في كوروناري، لان الانفلاميشن له اهميه. وعشان كده في ناس بياخدوا ستاتين وبرضه بيجي لهم كارديوفاسكولار ايفنت، لان الانفلاميشن ما بيكونش كافي بالستاتين، محتاج حاجه.
The recording has stopped.
الصوت راح.
هو دكتور حسن شكله خرج بس وهيرجع تاني ان شاء الله. هنستنى بس دكتور احمد محسن لو موجود يحط السلايد.